Welcome to this comprehensive nursing study guide. Today, we are performing a deep dive into the two major disorders of the adrenal cortex, Cushing syndrome and Addison's disease. To understand these disorders, we must first look at the adrenal cortex. It is responsible for secreting three vital classes of steroid hormones, often remembered as sugar, salt, and sex. Glucocorticoids, primarily cortisol, regulate sugar metabolism. Mineralocorticoids, like aldosterone, manage salt and water balance. Androgens regulate sex characteristics. Cushing syndrome represents a cushion of excess cortisol. The most common cause is iatrogenic, resulting from long-term, high-dose glucocorticoid therapy for other conditions. Endogenous causes include pituitary tumors secreting excess ACTH, known as Cushing's disease, or tumors within the adrenal glands themselves. Clinical manifestations are striking. Excess cortisol leads to fat redistribution, causing the classic rounded moon face and a buffalo hump on the upper back. Patients often present with truncal obesity, where fat accumulates in the abdomen while the arms and legs become thin due to muscle wasting and protein catabolism. The skin becomes fragile and thin. You will see purple striae or stretch marks on the abdomen, and the patient will bruise very easily, a condition called ecchymosis. Metabolically, expect the highs, high blood sugar and high sodium. However, potassium and calcium levels typically drop, leading to hypokalemia. Diagnostic gold standards include the 24-hour urinary free cortisol test. Levels exceeding 100 micrograms per day are highly suggestive of Cushing's. Another key test is late-night salivary cortisol. Normally, cortisol drops at night, but in Cushing's, this diurnal variation is lost, showing high levels at midnight. The dexamethasone suppression test is also vital. If cortisol levels remain high after receiving dexamethasone, it confirms the diagnosis of hypercortisolism. Nursing priorities focus on infection control. Because cortisol suppresses the immune system, signs of infection like fever may be masked. Monitor closely for any subtle changes. Glucose management is critical. Many patients will require frequent blood sugar monitoring and may need insulin coverage due to cortisol-induced insulin resistance. Meticulous skincare is essential to prevent breakdown. Avoid using harsh tapes or adhesives on their fragile, paper-thin skin to prevent tearing and infection. Monitor for fluid volume overload, including hypertension and edema. Nurses must also watch for cardiac arrhythmias related to low potassium levels. Moving to Addison's disease, think of absence. This is primary adrenal insufficiency, where the adrenal cortex is destroyed, often by an autoimmune response. Secondary insufficiency can also occur if long-term steroid therapy is stopped abruptly, leaving the body without its necessary supply of cortisol. A hallmark sign is hyperpigmentation, a classic bronze-colored tan that appears even without sun exposure, particularly in skin creases and on pressure points. Patients feel low and slow. Expect profound weakness, fatigue, and postural hypotension, where the blood pressure drops significantly when standing. Laboratory findings show the lows, low blood sugar and low sodium. Critically, potassium levels rise, leading to life-threatening hyperkalemia. The definitive test is the ACTH stimulation test. Synthetic ACTH is injected, and if the cortisol levels fail to rise, it confirms Addison's disease. In primary failure, the adrenal glands are simply unable to respond to the ACTH signal, regardless of how much stimulation they receive. Management requires lifelong hormone replacement. Glucocorticoids are given in divided doses to mimic the body's natural rhythm, 2/3 in the morning and 1/3 in the afternoon. Unlike most patients, those with Addison's may need a high-sodium diet, especially during hot weather or strenuous exercise, to prevent vascular collapse. Patient education is a lifesaver. They must wear a medical alert bracelet at all times and carry an emergency injectable hydrocortisone kit. During times of high stress, such as surgery, illness, or trauma, the patient must be taught to increase their steroid dose to prevent a crisis. Let's summarize the key differences. Cushing's is high and cushy with high BP and sugar. Addison's is low and slow with low BP and sugar. Cushing's presents with weight gain and striae, while Addison's shows weight loss and the hallmark bronze hyperpigmentation. The most feared complication of Addison's is the Addisonian crisis. This is a life-threatening emergency caused by a sudden, sharp drop in cortisol. The patient will experience severe hypotension leading to vascular collapse. This circulatory shock can be fatal if not treated aggressively and immediately. Treatment priorities are IV hydrocortisone, often as Solu-Cortef, and rapid fluid resuscitation using isotonic saline or dextrose-containing solutions. For Cushing's, surgical removal of the tumor is common. Post-operatively, nurses must monitor for a rapid drop in cortisol levels, which can mimic Addisonian symptoms. Carefully monitor blood pressure and electrolytes after an adrenalectomy to ensure the patient doesn't slip into a temporary state of adrenal insufficiency. Here is a major NClEX tip: never stop steroid therapy abruptly. Tapering is essential to allow the adrenal glands to resume their own production. Always remember that potassium is the priority electrolyte in Addison's. Watch for peaked T waves on the EKG, which signal dangerous hyperkalemia. Long-term management for both conditions focuses on adherence to medication, stress management, and regular follow-ups with an endocrinologist. Ensure your patient understands their stress dose rules and the importance of their medical alert ID. Their life depends on this knowledge. Mastering the adrenal cortex is a huge step toward your nursing license. Keep studying these contrasts, and you'll be ready for any adrenal question on the NClEX.